Pegasus TIMI 54 demonstrated that long-term secondary prevention with ticagrelor reduced cardiovascular death, MI, or stroke in patients with a prior myocardial infarction. Now, as we look at the data, we're trying to understand the efficacy and safety of long-term secondary prevention in important subgroups, and one of those subgroups are patients with peripheral artery disease. It's important that this population in Pegasus is a population of so-called polyvascular disease. They've had both a prior myocardial infarction and peripheral artery disease. And we know that those patients are at heightened risk of ischemic events, including limb ischemic events, heart attacks, mortality, and bleeding. And so we felt it was important to understand the efficacy and safety of therapy in that population. The primary results of this analysis in the PAD subgroup were that patients with peripheral artery disease were at higher risk of cardiovascular events, so MI, stroke, and cardiovascular death, as well as all-cause mortality and limb ischemic events relative to MI patients without PAD. And that relationship with risk was preserved even after we adjusted for differences in baseline between the two groups. In terms of the efficacy and safety of ticagrelor, we found that the efficacy was similar in those with and without PAD in terms of the relative risk reduction. But because the PAD patients were at such high absolute risk, that translated into a robust absolute risk reduction of over 4% when you look at the doses combined, or with the 60 milligram dose of over 5%, and a very low number needed to treat. In addition, we found that the bleeding signal for ticagrelor was similar for patients without and with PAD. There was no difference. And we saw in an exploratory endpoint that there was a reduction in adverse limb events with ticagrelor, which was an exploratory endpoint, but something where we saw a reduction. Pegasus looked at two doses of ticagrelor. One was the 90 milligram dose that had been shown efficacious in the ACS trial Plato, and one was a lower dose, 60 milligrams, which was thought to potentially have an optimal blend of efficacy and safety for long-term exposure, long-term secondary prevention. Overall, both doses reduced events to a very similar extent versus placebo in the trial. We saw no heterogeneity for either dose based on the PAD population, but when you look at the actual endpoints, you see that the 60 milligram dose actually has significant reductions for cardiovascular death and mortality, and a more robust absolute risk reduction and relative risk reduction. And whether there are truly differences between the doses, we didn't test that in the paper. We have seen that pattern throughout the trial. The 60 milligram dose looked particularly attractive from a risk-benefit profile, and perhaps because it's a better tolerated dose, there was better adherence with the 60 milligram dose. But overall, it's very reassuring because that's the dose that's labeled for use. I think the take-home message is that in the prior MI population, if clinicians are thinking of which populations are going to get a robust benefit from long-term ticagrelor therapy, that I would say patients with peripheral artery disease and prior MI, it's one of those populations that will derive very robust risk reduction.